Hi everyone and welcome to Imaging Experts Pakistan. Today we are going to discuss about the claustrophobic and needlephobic patient. We have got Mr. Benjamin Daniel Peak with us. He's an expert radiographer, and in his introduction I will say I've learned a lot of things from him. Welcome to the Imaging Expert Pakistan, Daniel.
Thanks for having me, Murder.
Nice to have you here at Imaging Expert Pakistan. Would you like to give your introduction to our listener, please?
Yeah, so my name's Dan. I actually go by my second name, so not so much Benjamin, but yeah, Daniel. I was born in Australia, so that's where I studied radiography and worked for 4 years before moving over to the UK, where I've been living over here for 9 years. So yeah, I've got roughly about 15 years experience in radiography. Specifically now in MRI, I've been doing that for the last 10 years. So I've roughly worked sort of 3 different countries, 20 different hospitals. So I've been around lots of different environments and used lots of different equipment and stuff like that. So yeah.
Cool. We'll start with our topic now. Like, how can we recognize if someone is claustrophobic?
So there's lots of different cues that you can pick up with people. Quite often people will just tell you I'm claustrophobic or I'm worried about this scan and stuff like that. So those ones are quite easy and easy to manage, which is much nicer. Sometimes some people will be a bit more reserved and you have to try and pick up on certain things. But it's quite easy to do, like with experience. So quite often you'll see people will appear nervous. Things that might tell you that they might be nervous is they might have poor eye contact, their body language will be closed off. They can also be a bit agitated with you and things like that, and sometimes even be aggressive. So picking up on those sort of things will tell you that they're not too happy to be there and to be doing what they're doing. So that might give you a hint that they're claustrophobic. Some people will exhibit all those things and swear to you black and blue that they're not claustrophobic. So some people don't like to admit these sort of things as well. So, but we still have to recognize them and manage it because roughly sort of 5 to 7% of the world's population suffer with claustrophobia. So if you're scanning 20 patients a day, there's a good chance at least one of those patients will be claustrophobic. So it is part of our job to try and help these patients through the scan, and it's one of the challenges that you face with working in an MRI department because of the equipment, how it's sort of set up is quite claustrophobic for people, unfortunately. Yeah.
Before we go to the preparation of the patient, I would like to ask, like, in a normal definition, what is a claustrophobia for the people to understand?
So quite often claustrophobia is described as like an irrational fear of an enclosed space, which most people, when you do have these claustrophobic patients, they do realize that it's irrational and stuff like that, but quite often that doesn't help the situation quite often. So claustrophobia is an irrational fear of enclosed spaces. That's how, yeah, that's the dictionary definition of it, pretty much.
Okay, cool. So about the preparation, how would you prepare a claustrophobic patient?
So there's a couple of different things that you can do to prepare these patients. The first sort of step is to get them in as early as possible. You don't want to be rushed with these patients. So if you did have an opportunity, if you knew they were coming in, you knew they were claustrophobic, normally you'd get patients to come in maybe 15 minutes before. You might ask these ones to come in a bit earlier because they're going to have more questions and stuff like this. And you don't want to be rushed with these patients either. So yeah, getting them in early is really good. Also, like going back to sort of the definition of the irrational fear, it's when you're communicating to these patients, it's about normalizing what they're feeling. That even though we might say it's an irrational thing, it's not. It's rational to feel anxious when the possibility of you being trapped, and that's what these patients are going through. So that's actually very, very normal. The irrational part is they're not actually trapped. It's an MRI machine, it's open. That becomes the irrational part. So yeah, if you can normalize the condition as much as possible, so telling patients that plenty other patients suffer from this, that you deal with this sort of thing on a daily basis in MRI, just so they feel like it's not irrational, what they're going through is normal. And that really helps patients, I think. A lot of MRI safety questionnaires these days will have a question. The first one will be, have you ever had an MRI before? So if they have had one before, what was it of? So if it was the same sort of body part that you're scanning, well, then you can sort of reiterate that it's going to be similar to what they experienced before. If it's a different body part, so say maybe they had a head scan previously and this time they're doing a pelvis, well, then you can say, well, they're not going to have the head camera around them, and that most of their head could be out of the machine a little bit more than previously. So finding out that. If they haven't had one before, why are they nervous? So sometimes they've got a relative or a friend that's claustrophobic, that's had a scan that's described a very awful experience to them. So then they're naturally concerned and worried. And also, if you've never done something before, it's normal to be anxious about doing that thing as well. So that's an important step to find out, because if they've had it before and they went through it, you know what worked for them last time. So ask them, okay, what worked for you last time or what didn't, and then see if you can tailor the scan a little bit to the patient, because everyone's a little bit different on what their needs might be when it comes to the scan. So yeah, preparation with that sort of thing is really important to sit down and talk with them pretty much. So that's why getting them in early is important, so you can have the time to chat with them really.
Okay, and what is the importance of the communication while dealing with the claustrophobic patient?
So quite often we're doing fairly long scans. There's no sort of time reference in there and things like that. So constantly talking to your patient in between the sequences that you're running is very important, and isn't that time consuming either. Quite often people just want to have a timing, so you can tell them you've got 30 minutes left to go, the next one's going to be 5 minutes, and I'll talk to you after that one and give you another update. So it's constantly trying to give them an update so they can mentally sort of prepare themselves for how much longer they'll have to be in there for. And then also sort of communicating the symptoms that they might feel. So there's sort of common symptoms that you can get with claustrophobia, where you can feel like your heartbeat is racing a bit more. You can get shortness of breath. So quite often patients will describe that they can't breathe, and also they can get some dizziness. So communicating to them that those are some of the sensations that they can feel is important, so then they know that to expect that. And then also to try and tell them that it will pass as well. So these symptoms, everyone gets them. Even if you're not very claustrophobic, everyone can get these feelings of anxiety and stuff like that. But we all know over time, these things just gradually dissipate. So quite often I'll tell patients to try and just get through the first 5 minutes, and then most of their symptoms will subside. You'll talk to the patient, you'll hear it in their voice, they're much calmer and relaxed the further you go through the scan. And so I find more often than not, you get through the first 5 minutes, you'll do the whole thing. Every now and again, someone might press it because they've freaked out a bit later on. Maybe you've given them an injection of contrast and that's brought the anxiety back, or something like that has triggered it again. But yeah, more often than not, I find getting them through the first sort of 5 minutes is very important. So yeah, communicating through that whole process and explaining everything that will happen is important.
Okay, so what equipment aids can be used, or what medication can be used for the claustrophobic patients?
So different equipment that might be available to you is like some people like eye masks. Not too many, I don't think, actually, from my experience, but every now and again people do appreciate that. Some people find an eye mask might add to the claustrophobia because it's just something else on top of their face and stuff like that. But some people do respond to that. So just giving them that option, and then they can choose, because it's just about removing that temptation of looking. There's nothing to look at in there anyway, and I'll always tell patients to just close your eyes because there's nothing to look at in there anyway. But you tell people that they just can't help themselves. So that's where the eye mask stops them from doing that. So those sort of things can be useful. Also, people are probably quite familiar with the head coil usually has a mirror on it if it hasn't been broken in a department or something, but that's why it's important to get those things replaced. But that'll sit on top and people can look out of the machine then, which is quite nice. There's also glasses that do the same sort of thing as those, where you can pop those on and you've got reflective mirrors that sort of look out of the machine as well. You can adjust your equipment on how you use it as well. So how you position the patient. Are you going to go in feet first, head first? Do you have a choice? If you've got a choice, more often than not, feet first is a better option for claustrophobic patients, so the head don't have to go in first and all the way through. If you're using pillows, quite often you can be propping the head up higher to the roof of the machine and then increasing the claustrophobia. So when you're putting them on and using your equipment, make sure you're sort of telling them that there are different options that we can set you up that might be more comfortable to you. Also, I've also done plenty of scans where, like, I think only just a couple of weeks ago, I had a patient that couldn't tolerate the top of the head coil being on the machine. So I did the scan without the head coil, the top of it on. You did lose a bit of signal at the front, but the images were still diagnostic. So that's important to do as well. So sometimes you might not be able to get the prettiest pictures in the world, but you'll get something which might be enough to give the patient an answer to what the problem is they're having. So don't think that you can't just do something because you can't close the head coil or something like that. You can still run it and see how it goes. Get a claustrophobic patient, I kind of like it because then it means I can do some nice quick pictures. I've got a good clinical reason to shorten my scanning time down. Now that does reduce your quality, but quite often in most places our quality has been put to like an optimal level, and that we can reduce that a bit and you'll still produce diagnostic images. So yeah, shortening your sequences as much as you can is good to do as well. Also trying to answer the most clinically relevant question first with the sequences that you're running. So for example, if you're doing a brain and it's a stroke patient, you might do your diffusion scan first. Or if it's a patient where you're doing an inner ear problem with the brain, but it's mostly dizziness, well, then you do the inner ear because that's where it's most likely is going to be the problem. So you can do things like that. So even if you only get the patient in there for 5 minutes, you've done the most important things first and you still might get them the answer, because quite often we're doing a lot of extra imaging these days to pick up lots of different pathologies and stuff like that. But more often than not, there's one clinical question we're trying to answer in a way which will be answered by 1 or 2 sequences. So utilizing your equipment in that sort of way is good to do as well.
Yeah. Also, you can offer the headphones and you can play the music or whatever they want to listen during that time.
Yeah, thanks for bringing that one up, actually, because music is like something I'm very passionate about, and I love music. I nearly like DJing for my patients more, just as much as I like doing the scans, because music is a powerful tool for a lot of people. So putting the right music on for the right person. So if you've got choices with that, it's really good. If you've even just got some relaxing spa music, that sort of thing puts people in sort of a relaxing mode as well. So yeah, good point with that one. Thanks, Movie.
Yeah, you can also play a lot of recitations from the different holy books or storybooks or geography, whatever you want to play from the YouTube. You can play it for the people who doesn't want to listen to the music.
Yeah, and there's also there's so many different ways you could sort of go down with this as well, because there's a lot of people that do yoga and breathing exercises in their own spare time now. So finding out if people have experience with those sorts of things are really good, because then you say, well, now's that time to use that stuff you've been training for. So doing breathing exercises and meditative techniques are very helpful as well. So talking to people about those sort of things can be good too. Oh yeah, you asked about medication as well. So sometimes if a patient calls me up and says that they're coming in for a scan, they're quite anxious. We don't normally provide medication ourselves. It's something they have to source from their GP or the referring doctor. So I try and warn them about that beforehand. And normally the drug that's used is something called Diazepam. It might be called different things in different places sometimes, but effectively it's pretty much a muscle relaxant that sometimes it's used to treat anxiety and that as well. It's not something that's going to knock a patient out completely, but it will just take the edge off things. Very rarely, I don't hear of it that often, that you'll have like a GA, general anaesthetic for a claustrophobic patient. I've heard about it, but it doesn't happen that often. So I don't really tell that as an option for my patients ever, that that's something that they can do, because it's super costly. It takes up lots of time, and yeah, you need lots of people to do that sort of thing. So generally that sort of medication and that technique is generally reserved for young kids and people with learning disabilities and things like that. So yeah, the main medication would be diazepam.
Yeah, you have almost covered everything. I just want to ask one thing: what things we should not do while dealing with the claustrophobic patients?
Yeah, so it's important not to rush patients and things like that. So just take your time with them. Also, you've got to listen to people, so you want to take the time to listen to what their concerns are. So don't just talk over the top of people and things like that.
Communicate and try not to force them.
One of the things that we do use is an emergency buzzer that people press. If someone presses it, stop the scan and talk to them. There's something that I'm seeing happening a bit more and more recently, because quite often a patient will squeeze the bell and it is something silly. Oh, I've left my ring on. What about that? And it's 20 minutes into the scan. So it's like, yeah, your ring wasn't a problem for the first 20 minutes, mate. So is it now? So quite often it gets pressed for the wrong reasons. So quite now I'm seeing, if there's a minute left to run on the sequence and the patient squeezes the bell, the radiographer's there going, you've just got one more minute, just keep going. Now, at the start of the scan, we've told them that's an emergency buzzer and we will stop and talk to them if they squeeze it. Well, now we're not doing what we said we would do. So we've destroyed the trust with the patient. And I'm seeing a lot of patients now come to see me that they've told me they squeezed the buzzer and nothing happened. So please, if they squeeze the bell, stop the scan. There's certain equipment that's where, like GE scanners, for example, you can pause the scan. So do that. But if you're on Siemens and the other ones, you'll have to stop it. This is annoying when it is like maybe a contrast scan that you're doing with different phases. So if I've got a really nervous patient, I will tell them at that point that if they squeeze the bell, then I'll have to stop the scan and we might lose the contrast and they won't get the pictures that they need. So only squeeze it if they absolutely have to. And yeah, so that would be another thing not to do. And yeah, and just generally don't be too aggressive and pushy with these patients. And that might be understanding you on that given day. As good as I think I am with patients on most days, I'm not at my best sometimes too. So it's realizing that. So if you're not in a good headspace and a good way to deal with a very needy patient, ask one of your colleagues that's around to help you out, that maybe they take the lead with this one in particular. So that's a good point as well, I think.
Okay, just a quick question about the needlephobic patient. I know that some people are very needlephobic as well. So how to deal the needlephobic patient?
Don't tell them it's not going to hurt, for starters, because having
Sharp
a needle
scratch.
yeah, that's the common one that people say is a sharp scratch. I suppose you don't want to say this is going to hurt like hell either, but so you can't win maybe. But yeah, you just say it's going to be uncomfortable, but you're going to make it as painless as possible. With those ones as well, it's important that I would always do those patients laying down or in a cannulation chair that can be laid down in case they faint on you and things like that. You don't want them in a chair falling over, slumping on the ground and things like that. So make sure you're doing them laying down. and being prepared, having everything ready. You don't want to be going, oh, where's this? I didn't get that halfway through. So having your tray set out, all the bits that you need and that as well. Sometimes it helps if you've got a colleague that can talk to the patient and distract them for you, and those things will help as well.
Try to find the better vein where you can just do it easily and gently.
Yeah, so check both arms, always check both, don't ever check one, because you'll do one on one side and then all of a sudden you've missed it and you look on the other side, there's a big juicy one there. So always choose the best one. Sometimes these patients, they're quite difficult at times because they do put the pressure on you. Try not to feel that pressure, because a lot of the time they'll say, you have to get it in the first time and things like that. And please get it in the first time. And look, you're always going to try your best. I always tell my patient, well, I don't mean to miss what I miss and things like that. So try to manage their expectations as much as you can, and yeah, just do your job that you know how to do, and not let their anxiety and pressure come onto you, because that's when it gets a little bit more tricky. If you've had a couple of goes, get someone else and get a fresh pair of eyes, because yeah, quite often I find once I've missed twice or something like that, I'm starting to get a little bit more frustrated with the procedure as well. So getting a fresh pair of eyes and someone else in there as well. Using the correct needle for the type of scan you're doing as well. So if you're only doing a hand injection, you might consider just using a smaller needle, so as small as possible, because that's a good mental thing for the patients to hear, that I'm just going to use the tiniest needle I can use and things like that. Some of these needlephobic patients don't like it sitting in there for a long period of time as well. So sometimes it might be good to just pop the cannula in when it comes time to do the injection. That's personal choice though, because sometimes that can be a bit frustrating too, to bring someone out and then your cannula and they've moved from their original position. So if you can, it's best to do it at the start, but sometimes the patients might not want it in there for a long period of time. I think it's good to not take it out straight away, because some people want it taken out straight away after, but there is a chance that some people can have delayed reactions to things. That's the most common reaction I've probably seen with using MRI contrast, is that after the scan they break out in hives or something like that. If they've still got the cannula in, you can easily give them some medication and stuff to sort that out. But yeah.
Cool. So at the end, would you like to give any advice or any message to the radiographers, junior radiographers, or the student radiographers?
I suppose for me, my advice is just like, yeah, really enjoy what you do. Bring your personality to the job as well. You don't have to just be a robot and say these things a certain way. Bring your strengths to the job. So for me, I really like people and things like that. So I get a lot of enjoyment out of getting these claustrophobic patients through and talking to them and understanding them and helping them through the whole process. So that's a really positive thing that you can get out of the job, because you're helping people and you're helping someone that might not been able to get that scan without you being there. So taking a lot of pride in that is good. And yeah, be yourself and yeah, enjoy what you do.
Thank you so much, Dan, for your time, and it was a pleasure talking to you.
No worries. Thanks, Mudabir.
Thank you. We are going to end this episode here, and we'll come back with another episode soon. Thank you.